Welcome and good morning. My name is Kristen Stewart, and I am a member here at St. Bees and a member of our Justice Ministry. And we are so excited to be kicking off a brand new series this week. And so I want to kind of give you an overview so you know what to expect each week. Each week we will have one or two guests who will share about an issue that is facing our neighbors here in Nashville. As we join NOAA, there are issues that NOAA focuses on, and we wanted to introduce our congregation to those issues and some of the people who are working in our city on those issues. And then we had some extra space, so we added an issue of our own that we have addressed in the past. We had Michelle Johnson from Tennessee Justice Center. So we're adding healthcare, and that is going to kick us off this time. So each week we're going to have people come and share from their expertise. And then we will close it with some opportunities to learn more and to get involved here in our community. And so before we start, while people are still trickling in, I have two announcements. You may have heard Jamar Tisby and Jim Wallace are going to be speaking on Thursday night. There's still room available. So if you're not doing anything on Thursday, that should, I believe it was in the Justice email that went out last week. From Serena, but if you need more information, just find me after. If you just Google Nashville, Jim Wallace, Jamar Tisby, the Eventbrite will pop up for you. But that is happening on Thursday evening. And before that, it just happens that one of our wonderful speakers today, Dr. Rhonda Switzer-Nadasdi, her organization Interfaith has their annual breakfast. I'll be attending. So you can come and sit with me. And it's at Geodis on Tuesday morning from 7 to 8:30 a.m. So you can still make it to work. There are flyers in the back for you to register for that. So those are two events. I am going to tell you just a little more about our class as people are trickling in. The idea for this class was that we know that one of our responsibilities as Christians, one of the things that Jesus calls us to is to love our neighbors as ourselves. And one barrier to loving our neighbors is not knowing our neighbors, especially our most vulnerable neighbors, and not knowing what their needs are, how we can love them better. And so the idea behind this class is that we would learn about what some of our neighbors in Nashville are facing so that we're able to love them better. And so I'm going to open us with a prayer, and then I'm going to turn it over to Dr. Julie West and Dr. Rhonda Switzer-Nadasdi. I'm going to let them introduce themselves and tell you more about how they got onto this work. Almighty God, whose blessed Son, Jesus Christ, went about doing good and healing all manner of sickness and disease among the people, continue in our communities his gracious work amongst us. Console and heal the sick. Grant to the physicians, nurses, and assisting staff wisdom and skill, diligence and patience. Prosper their work, O Lord, and send down your blessing upon all who serve the suffering. Through Jesus Christ our Lord. Amen. All right.
Good morning. You can hear me in the back? Yeah. Thank you for welcoming me. I think I know someone in every row, and that just makes my heart sing. This is preaching to the choir. You're already so active. So I'm a Canadian-born, Canadian-trained dentist, and my mission was really not to work with the underserved and help my neighbor. It was really to do some great dentistry, and somehow my career just went from the very beginning, and I blame my parents who had me at church every Sunday morning and were very active in the community. And when the first job came around to serve at a VA hospital in Louisville, that's what I did. And then I spent a couple years in the Canadian Arctic with the underserved Inuit people, and then in Bermuda with Portuguese families that were struggling to find oral health care. So when my musician husband proposed, and he was living in Nashville, and I didn't have a green card or a license or a job, of course I jumped at the opportunity to come to Nashville. And I found this dentist who had started a tiny clinic in the basement of West End United Methodist Church, and he was the kind of individual you didn't say no to, and so I took the job. And we could still be in that church flourishing, but every person involved said, we could do more, we could do more, we could do more, and pretty soon it became my mindset. So now we are 30 years in existence next week, and we cared for 3,722 people last year. And we have 2 facilities, one in Nashville and one in Murfreesboro, with 26 treatment rooms, 100 volunteers, including Dr. Clay Sparrow back there, my friend, and Dr. Elizabeth Sparrow, who used to serve on our team, and many, many others. So thank you for welcoming me.
Hey, I know most of you. Am I loud enough? I can be louder. Okay. Julie West, I've been a parishioner here for almost 22 years, and then prior to that, 4 years with a hiatus. So I'm an internal medicine trained physician, done primary care and hospital medicine. And it's funny that you'd say it's your parents brought you to church. My initiation to serving those in need was when I went on a missions trip at age 16 to Haiti to paint a building that was a school, as well as redo roofing, the corrugated roofs. But I went because I knew at the end of the trip they were doing a beach get together. And I thought this would be a great way to get tan. I'm going to totally out my narcissistic 16-year-old self. And I was absolutely blown away at what it meant to serve others and what it meant to serve others who were in need and low resource. So I came back, fast forward, went to Wheaton College, spent time in West Africa, cut my teeth caring for patients as a nurse, and then had always really realized I thought I wanted to be a physician. So that's where I headed, and I had a wonderful boyfriend, now spouse, who said, if this is what you want to do, I support you. So went to medical school, residency, et cetera, and have worked in various care settings, private practice initially because I couldn't find a job in the safety net. No one was hiring. It was very fascinating. But nothing's lost in God's economy, and I learned a lot in private practice, and then spent 16 years after that at Vanderbilt doing primary care in a community academic partnership with a federally qualified health center, which we'll mention in a few minutes what that is, taking care of people experiencing homelessness, and also building curriculum for medical students and residents. And then, almost a year ago this week, I learned, and a few people got in touch with me, that Siloam Health was looking for a new chief medical officer. And I said, I don't have experience in that. I've done some other things, but God had other plans, and so I've been the CMO at Siloam now for 4 months. I am learning what I don't know more than what I know in this space, but I can tell you that Siloam has been around for almost 33 years. And has had a windy road of their underserved charitable care patient population, mostly now refugees and immigrants. Last year, we served around 6,600 people between 2 clinics. And with that, over 20,000 different visits of those 6,600 unique patients, with multiple languages, 80 different countries, 50 languages spoken, the majority of which is Arabic and Spanish. So that's my current place, but I have experience and hopefully things to share from working in the safety net in Nashville.
So Julie charged me with giving you an idea of what the landscape looks like in healthcare in Nashville. So because our state is lower taxes, there is lower services. So a lot of charitable care efforts are here that don't exist in other cities. So in Nashville itself, there's health department. So that's the Lentz Public Health Center. And it operates not directly under the Department of Health. It has some of its own rules and guidelines that it doesn't have to abide by of the state. So there's that health department, and they do have a dental clinic there as well. And then there's federally qualified health centers. So that's your neighborhood health that Dr. West served at, and Matthew Walker Comprehensive Care Center, and then Connect Us Health, which is not too far from here. I think it's the closest one. So those federally qualified health centers operate under large grants from the federal government. So they have to meet some federal guidelines to do what they do. And they have regulations on that they have to serve everybody that walks in their door, no matter what. And both Matthew Walker and Neighborhood Health offer dental services there. So we were also blessed to have Meharry Medical School that also has a dental school. So they have clinics for underserved, both of those. And at that clinic at Meharry, it is about half price for the for the dental to be able to go there. And then, of course, Metro General, which is our major charitable care hospital, and then whatever pro bono the other hospitals do. And then you've got the private charity clinics, which are Siloam and Faith Family Medical Center, and Interfaith Dental, and there's Hope Smiles as well. So it's a pretty big group. Believe it or not, that group does meet together. It's called the Safety Net Consortium of Middle Tennessee, and we all get together to talk about how we can have greater impact. So all those places have unique things that they bring to the table. Some use volunteers, some, like I said, have the federal dollars, some are connected with Vanderbilt for residents. We have oral surgery residents that come to our clinic. So they all bring something, but the thread in common is they're all serving those that are underserved, either because of lack of access from discrimination or language, insurance that makes them underinsured, or being able to get there from a transportation kind of perspective. So then a little bit about Medicaid and Medicare, which a lot of people confuse the two things. Medicare is just for over 65. Medicaid is for the other group of underserved people. Now, the thing in our state is that it's very difficult to be on Medicaid. For one thing, you have to meet the 5-finger test of being on Medicaid. Does anyone know what that is? So to be on Medicaid in our state, which now, for the last 30 years of Interfaith Dental, there wasn't any dental in Medicaid in our state. In the last year, it has the dental. But even for the medical and the dental, you have to be pregnant, be a child, have a child that you're responsible for, have breast or cervical cancer diagnosis and treatment, or be on SSI, which is usually a very limiting physical mental health challenge. So if you are just a rich person and you're poor and you don't meet any of those, there is not a Medicaid safety net for you, which makes all the clinics that I mentioned that you can pay on a sliding fee scale a key thing. If our state was to expand Medicaid to include more people, then that would definitely improve the situation. What did I miss, Dr. West?
I missed much. I have just one stat. So in Tennessee, we have 15% of our population that is uninsured. The overall average for the U.S. is 10 to 12, depending on when you look. And in Davidson County, we have 16% of our patients that are uninsured. And to clarify also what Rhonda said, Medicare is for 65 plus, and Medicaid, which we call TennCare, so they're the same, is for ages 19 to 64. And that is the same bracket that the bucket of safety net funding that's federal through the state that Rhonda mentioned comes to. So it's to cover that group of people. And that, you got it.
Yeah. Since you were hot on the stats, do you want a few more stats? I think so, yeah. So there's 424,000 workers in Nashville, and half of those are living on less than what we determine as living wage. 82,000 Metro Nashville public school students, and half of those are low income. 44,000 single moms, and half of those women and their children live in poverty. So when you think Nashville and you look downtown, and I was downtown last night, it's so booming and all the cranes and everything that's happening, a lot of people are being left behind. In fact, the poverty rate in Nashville is just as bad as it was a decade ago when this boom started. And the poverty rate, sorry, my glasses, here in Nashville is higher than its peer cities and most of the United States, and it's at 14%. 1 in 10 Nashvillians are food insecure. So if you're food insecure, you're probably not having dollars for health care. Let's just put that out there. And that the most of the jobs that are coming here are lower skilled, low wage types of jobs. The zip codes with the highest food insecurity are 37207, 37208 and 37218, and all those zip codes touch Nashville. But there's things we can do.
There's things we can do. Okay. Well, the next question that was requested of us to talk about is the barriers of accessing care and the big picture, root causes, et cetera. And so Rhonda's already touched on something, and the reality of your health is that there's multiple things that wrap around you being healthy. And the biggest reason that people have poor health is poverty. Okay, so there's a social gradient that's been studied for almost 50 years in multiple cities, countries, that poorer people, lower socioeconomic status is absolutely correlated with poor health. So that is an issue. So you think about, let's help in the safety net, let's volunteer, super important, but you're pulling people out of the lake or the water and they're still getting thrown over the cliff, right? So we want to think about what we can do to hit these social drivers of health, some kind of renamed from the term social determinants of health. So the things that we think about that wrap around health are social drivers, which include where you're born, live, work, grow, age. So things like what we're going to talk about in the next few weeks of this class: housing, education, income, living wage, food security, and neighborhoods. Do you have sidewalks? Do you have playgrounds? Do you have well-lit areas? So those are some of the things that I think of for root causes, which is overwhelming and big, but it's just the truth. And this has been studied in multiple countries and cities. Other issues to accessing care, well, those are the barriers. The issues to accessing care are completely linked, and that includes transportation. You know, we don't have a great public transportation, and hot tip, it's on the ballot.
Way down, scroll all the way down in the ballot, you can find it.
Hot tip. And we're actually really excited as a little put a pin in this. In a couple weeks, our mayor is coming to speak to us about transportation initiatives. So transportation, cash, because even though there's a sliding scale in most of these clinics, and the clinic where people experience homelessness is free, you still usually have a cost for prescriptions. You have the lost wages from your day job or your day labor job or your job that is for a big box company that pays you for 30 hours, which is not enough for insurance and not enough, obviously, to get Medicaid in our state. But I'm sorry, we don't have Medicaid. You can't get that anyway, but not enough to go on the ACA and on the marketplace and get insurance. So those are a few things. What am I missing for access?
Right, but I also think it's language, big time, and it's just comfort level going to that place. Like, is that place for me? And how much time the person spends with you getting to know you. So you can have access to care, but it doesn't meet your needs, right? So I think that's the other piece.
Yeah, that's good.
Yeah. Okay. So you said, drivers. So I got to put my oral health plug in, right? So when we think about a cavity, teeth are the strongest bone in your body. We dig up fossils with teeth in it. They're supposed to last your lifetime. So if there's a big hole in your tooth, like Houston, we have a problem. This is the first warning sign that something's going on in there, right? Big time. So it's a big link to there's more going on in this person's life, right? Diet, stress, environment, all these other things at play. So critically important, especially when oral health is such a driver of employment. So at Interfaith, we talk about restoring, minimally at least, somebody's social six, which is their front six teeth, which is actually scientifically proven that the condition of those front six teeth determine employment possibilities, because so many judgments are made based on, they don't care, they're not educated, they must have had a drug problem, all those things if you look at someone's front teeth. So there's a lot of confidence and mental health going on there, but also what is connected with overall health and where that starts. So we know that there's connection between diabetes, heart disease, stroke, certain cancers, with oral health, that if your oral health is poor, it makes those risks and conditions worse, and then vice versa. So Tennessee is one of the, well, it is the worst. It is 50th in people going to the doctor for a well visit, meaning just going for a checkup to meet your doctor. So the first thing that young people have as a problem is usually a tooth, not something else, because it shows up there first. So it's quite an opportunity to intervene at some level there. So that's a big piece, and it's not something that there's emphasis on in society in trying to prioritize all the other parts of health that are health. Okay. Thanks for letting me plug oral health.
I actually, stepping up again to thinking of the barriers to accessing care, when I looked just kind of to refresh my memory, that a self-report, number one reason for not accessing care is cost. So it is, we talked about all the things in poverty, and the reason that cost matters is because people have low resource, but it's the loss of wages, like I said, it's transportation, it's that a lot of places, especially in rural areas or even in Nashville, some specialists aren't participating in the safety net, and so people will pay out of pocket. And even at our wonderful public hospital, they have financial assistance, and there is some percent that people pay. And the fear of medical debt is big, especially for our folks that are undocumented. They don't want to have medical debt, their address, people coming to look for them. A lot of our patients, when they're elsewhere, at least from Siloam, they pay cash because they want no paper trail. So that's an issue. And I also think we can't forget what we coined the working poor. So I referenced the people that even if we did expand Medicaid, they wouldn't be eligible. So they're at maybe 200% of the poverty level, which, by the way, 100% of the poverty level for a family of 4 is $41,000. So that's what our government thinks is, 100% of the poverty level. So if you think of folks that are working 1 or 2 jobs, that can't live inside our city, that have to have transportation, that group of patients or humans, when they look at, let's say they actually are offered insurance through their employer, they look at the employee cost and they will make a calculus in their head of, I am not willing to pay that portion because I need this income on a monthly basis for my family. So I just think that's also related to, like, we're talking about living wage, some of those things.
So deep breath. So let's talk a little bit about solutions and things that are going on. So one of the things that Siloam and Interfaith and some of the other programs do is try to lower costs of healthcare in how we're delivering it. So we know that if we look at all the other pieces for the person, because healthcare is just one piece of what makes you healthy, right? Your behaviors, your environment, all these other things. So if we're addressing those things, but it's also on how we deliver it, like not testing, just worrying about getting sued. Let's do that test, or things that are recommended. A 6-month checkup at the dentist was like made up. Like for some people, it should be more often, and some people it can be, if you're doing, the right things, longer than that. Don't tell anyone I said that, Dr. Sparrow, in a dental meeting. But like for real. So there are a lot of measures that we can be doing to drive costs down. Some is just good listening and getting to root causes with each person. So that's one factor. The other piece is, I listed all those programs that are there. It's about community awareness that those things exist, but it's also investing in the ones that are doing really good job as communities. And some of it is, private investment, but some of it is telling government officials about the good works and what they're doing. And then there's, of course, the volunteering aspect that we're going to talk about in a little bit. But I think let's comment on what we can do in our own lives as far as, it's personal volunteering, but then it's the businesses and things we're involved in. How do we make healthcare and the drivers of healthcare be at the forefront when we're making business decisions about wages and hiring and providing insurance and those kinds of things. And then there's advocacy itself in, letter writing campaigns, visiting your council people and talking about it, visiting your legislators on a state level, but also on a federal level. And that really matters. The loudest voices get heard. So.
Yeah. Well, that was basically what was on my list. But to tie it back to the comment about social determinants or social drivers, these things are all in that space of policy, economic, social, and political systems that have been built on, inequitable processes and built on the backs of people who were marginalized. So it's overwhelming to think that we can do something upstream, but I think that Dr. Switzer is correct, that it is having a voice and writing about expanding Medicaid. If you think that the transit policy is appropriate, if you want to be involved with, opportunities for housing, people that are in the industry of construction, let's have some dedicated space for lower income wage people to live. If you wanted to live in the Davidson County area, this was in the city does a huge study every year of a lot of socioeconomic issues. You'd have to have 2.5 jobs at the current, what is it, the lowest you can pay? Minimum wage, thank you. The minimum wage we pay, you'd have to have 2.5 jobs to live, to afford rent inside. So it's the folks that are on the end of that could think about how to have equitable process in your businesses and in your jobs. And then I also think bigger, that maybe there's people in the room here or not, but people that are in healthcare, in for-profit healthcare and other businesses that happen to drive up costs of insurance, pharmacy benefit managers, the issues with prescriptions. I mean, these are all big, but these are things that impact our class, but also the underserved and lower class folks, socioeconomic folks, because if we think we have trouble with that trickle down is really huge. So I'm just underscoring really mostly what you said, Rhonda, Dr. Switzer. But yeah, I agree. So
I think we're ready for questions.
Tell us what to do. Well,
Yeah.
Tom and Kathy wanted to. I had some. Actually, sorry. Since we have a couple minutes, I have something else. So I think it's really fascinating that the medical health care wing, allopathic medicine, osteopathic, and I'm sure dental too. There's been a lot of thought about poverty as a driver. So there's been some research on programs that are called anti-poverty medicine. So what would that be? And it's not just here's a food bank, right? But it's what can we do to kind of fight poverty? And it's things like medical financial partnerships, helping individuals or families with budgeting, with life skills, like how do you fill out a job application? You can't just leave something blank. Like that may be that may be germane to us that we know that, but some folks don't. So budgeting, finances, even how to save. So this is interwoven with like 3 or 4 of the big, maybe 6 healthcare systems, one in Boston and LA, that they're working with individuals and families as an anti-poverty measure because they know downstream that impacts health. Another thing that is interesting is the child tax credit that came out that was rolled back in 21. When that came out, child poverty was cut by half. And now that that's been withdrawn, child poverty is back up. Similarly, it's a little bit something people don't always agree on, but the concept of a universal basic income, UBI, when they've done studies with people that have been given just cash, in other countries too, especially pregnant women, and in the US, other groups of people, folks get out of debt and their poverty level is less. Similarly, when we had the COVID relief money, the stimulus, people got checks. I meant to look at the stat because I haven't looked at it in like 2 or 3 years, but people paid off their debt. They didn't go buy fancy shoes, a big car, a big TV, that some of the really biased opinions, a lot of what's out there for people living in poverty, debt was reduced. So I think that's really fascinating as far as how to address poverty. So that is kind of maybe not as exciting to end on, but maybe Tom and Kathy here can tell us about other ways to get involved. Unless, did you have anything else? Okay. And questions, please. We'll try.
That was excellent. Thank you so much. Very insightful. So, do we have questions?
I was just going to say, I wouldn't want to assume that everyone here knows what we mean when we use the term expanding Medicaid. And I wonder if maybe you would want to unpack that a little bit. What does it mean to expand Medicaid? Where is Tennessee among the states and not having done so? And what are the factors that sort of keep us from expanding Medicaid?
Okay, yeah. So I don't remember how many years ago, it was before the pandemic. The states have a decision to opt in or out of federal money to expand and fund their Medicaid program or TennCare for Us. All but 10 states opted into that. Tennessee is one of them. And there's a lot of reasons for that, and I don't sit in the spaces that has this conversation, but it's really cost. And they were given then block grants, money that they can choose to spend. And that's helped fund some of the safety net, but that is what expanding Medicaid means. It means our state and our legislatures who vote when they're in session to or to not accept this money. And my understanding, and you can chime in on this, is the main driver for cost is that after a certain point in time, some of the money lessens from the federal government or maybe completely goes away. I'm not sure about that. But the state has to pick up the baton, and our state has decided that is not where they want to put their money. Do I have that? Okay.
So I'd be curious, this is a great conversation. I'd be curious in the context, who in America, what state, what city is doing it well or right or the best if we are doing it not? That.
Yeah.
And
Yeah.
why, I guess, and why would they
Yeah,
have that?
so it's looking at, to me, doing it right means we have better health outcomes, we have longer lifespans, and we have longer healthy lifespans, right? So looking at that data, if you look at the states that are non-Southern states and states that expanded Medicaid, those ones are doing better. So like, was it Vermont? That had more progressive, yeah. Yeah, I mean, our health outcomes on most things were 45 or below.
And so it's Medicaid, it's the expansion of it and the access and availability?
Yes, yes. Environment of Tennessee has high smoking, very rural areas where we had a lot of our rural hospitals close. So there's a lot of, we're looking at statewide data. So like for Nashville though, being that we are the healthcare capital of the country. I mean, Nashville Business Journal says it, really is, but we don't have the health outcomes that our peer cities do. So who's doing it right?
I would say, just to answer Sean, I think the social and economic buy-in in some other places I suspect there's a correlation between the value of expanding Medicaid and the value of funding other entities that pre-K education and various things that wrap around our low resource individuals.
I apologize. I probably have a few questions wrapped into one. And first of all, thank you for what you're doing. I know, I have insurance, education, access, resource. I feel really privileged, and still I have had to change primary care doctors 4 times in 3 years because they keep leaving. So I can only imagine if I didn't have internet, all those things. So thank you for what you're doing. It feels, so my first question is, with all these resources you guys offered, does it feel like there is already enough services? Are there, even if people have access, transportation, I mean, I would suspect there's a whole lot of Nashvillians that don't even know these resources exist for them. Do we feel like what is already existing is sufficient to provide that care if people even know about it and can get there? Or is it even more needed? And then one thing I am thinking about is huge scale. I know that the healthcare system is very complicated and expensive, and there's 1,000 middlemen and all those kind of things. And I apologize to make this huge leap, but 10 years ago when I went to Italy, I had to go to the emergency room, get very dramatic stitches. It was a whole thing, and it was 20 euros. And I have to think, while that feels, in my mind, like a more equitable, a more affordable system for people, and obviously we have lots of steps to go Americans are generally afraid of change and making big changes, but does it feel like something like that in general is something to strive for, and in the meantime we have all these affordable clinics and making use of what we have with an eventual goal of doing something like that that's big? Or does it feel like we just have to work in this system indefinitely? I'm just curious your thoughts, because you are in it and you've also been all over the world to do medical care, so I feel like you've gotten exposure to different systems.
Well, it's who has agency, right? And the folks that are in the care in our clinics don't usually have power and agency to speak for themselves, even though we really work to help them represent themselves and represent them by us. But it's everybody else that, everyone thinks that you're going to lose something, right? Like, I'm not going to have my doctor, or I'm not going to have my thing if everybody has it. And so it's getting past that, but it's us that have good insurance that have the power to make the changes. And it's a give and take. It's a shared thing, but we can't sustain the costs going up like they are. I mean, we can't. Our insurance goes up every year, and we're not any healthier. Like, it needs to be completely blown up.
I'm going to answer really quickly, Elizabeth. The question about resources, I haven't really thought about that recently. I would say yes and no. Like, yes, we have a lot of excellent resources, nonprofits, private or publicly funded. How to get the word out, there's a lot of thoughts on that. So I don't know if we have enough to sustain. The second thing I'll say is, the reality of healthcare for all or universal healthcare is, there's a lot of countries that have that, and they end up still with the two-tier system because people that pay are going to pay for quicker care, access to specialists, et cetera. And I don't mean to be a pessimist, but we're a capitalistic country, and I just don't know that is in the DNA of the majority of Americans to want everybody matters or nobody matters. I don't know that is in the fabric of the majority of the voters. So I think there's a lot of benefit to it. That is not that I'm saying I don't agree, because I do. But do I think that's feasible? I don't know. I'm not optimistic. Anyway. Yeah.
Well, and I think the resources need to be focused on primary care, right? Like, there isn't a disease that has been cured by treatment. We got to prevent it in the first place, right? So, and that starts at the primary care level.
Tom, there's questions, but I know you wanted.
I don't have a question, but I work for the public health department, and I'm our manager for our community health education and prevention program within the behavioral health department. And so just to give you a little bit more context, Elizabeth, we have a ton of nonprofits in Nashville and resources that are available. And I think a huge barrier is just finding the people in those communities who are credible messengers to be able to go and talk about their lived experience, and then be able to say, here are the resources we have available. We have resilient community resources, we have behavioral health and mental health resources, we have resources for suicide prevention and opioid misuse and substance misuse, and they're all working together. So whether we see it or not, and whether or not it's actually making a dent in some of those numbers that Julie was talking about is one thing, but it is happening, and there are people who really want to combat the inequities that we have in our communities, and we are working on those social drivers of health, and we are trying to go upstream, but it is a hard and long process, and I think that we're going to be changing that one community member at a time.
It's a Sisyphean battle, I think. I just want to say, while we find the next question, that incumbent or implied in all the conversation is inclusive of behavioral health, and that is especially wrapped into those with immigrant and trauma experience. But the majority of people in poverty have had terrible traumatic experiences, if you're familiar with adverse childhood events and what that means. So it only follows that our lower resource neighbors need behavioral health, and there's just really limited options. The state has funding, we're all working on that, but it is also a need, I will say. So
I think some of what I'm thinking here is related to what Liz was saying. Well, one piece that is a pretty glaring piece to me is that when we look at overall budget nationally, a huge gorilla in the room is the fact that there's such an enormous amount of our budget that's spent on military industrial. And I don't think there's any way to get around the fact that there needs to eventually be some kind of at least modest shift of funding out of that huge piece of the pie toward other pieces of the pie. And honestly, and I don't think this is a partisan issue necessarily, at least in terms of Republican and Democrat, because I honestly haven't heard any major candidates in either of those parties be willing to make any kind of substantial move toward that. But I think we could make a huge difference in these pieces that you're talking about with that. Another thing is and this is maybe we need some new DNA pushed into our DNA as a country. Our philosophy of how we do business in this country is a real key. We seem to be really infected with the idea of this really top-down kind of who gets to be boss on top and make the majority of money in a business. And I see other countries around the world that have huge parts of their economy that are worker-owned cooperatives. And so there's groups like the Southeast Center for Cooperative Development that are working on these issues. That we can talk about democracy all we want, but that's a huge piece of our lives that doesn't have democracy in it if we don't have things like worker-owned businesses where there's more say of workers in those businesses.
I'll just say you're underscoring the issue of the social, economic, and political policies that drive poverty, which drives health, which drives well-being. So
I just want to ask, how many people in this room are involved to some degree or another in healthcare?
yay, my people.
He rests his case.
I just want to say that I'm glad that there are clinics that are taking care of the mental health issues. I've been a social worker at Vanderbilt. I'm now retired, thank God. But I've been at Vanderbilt for 28 years, and the last several years I've been in clinics. And there is a huge, huge need for mental health care in, I think, all primary care clinics. It's not being done. Great that it is somewhere, but I have never seen it, and I've not been able to access good mental health care for people that I've tried to get help for. Social workers, physicians are now out of the insurance business, so you have to pay private pay. When you have TennCare, you can get care, but the places that are taking, like Centerstone, there's a huge waiting list, or else they're putting everybody in groups. Not everybody can get care, what they need in a group setting. So there's a huge mental health need in our state and in our country.
Thanks, Pam. That's very true. Thank you, ladies. We appreciate it. Thanks for being here. And we're going to the Justice Ministry will make donations to your organizations. Please keep up the good work. Most, I think, probably all of us are insured. And so we know the importance of accessible, affordable health care, how important it is for us to be able to provide and to thrive and to achieve. We know, I think we're going to see over the next few weeks, this isn't an isolated thing. Transit, housing, education, jobs, and criminal justice, they're all intertwined. They all impact each other. And so I think that we're going to see, start putting the pieces together as the speakers come. I will point out the 5 things leave out a lot of men, a lot of young adults, Hispanics, unemployed, and obviously those low in education and income. picking up one more piece of the Medicaid, first off, I want to say to be in Nashville, the healthcare capital, and to be one of the highest rates in the country, that's just not right. We need to think, how can that be? So how can we be a part of changing that? The Medicaid piece, that we are one of 10 states who has not expanded Medicaid. Additionally, I don't know if you followed the news, but in August, a lawsuit was settled on behalf of thousands of plaintiffs on TennCare Medicaid. Since 2019, thousands of people had just been wrongfully disenrolled from the program. It was settled. The plaintiffs were represented by Michelle Johnson from the Tennessee Justice Center. I want to quote to you what Chief U.S. District Judge Waverly Crenshaw said in his opinion in favor of those people. Poor, disabled, and otherwise disadvantaged Tennesseans should not require luck, perseverance, or zealous lawyering to receive health care benefits they're entitled to under the law. So those people were asking for no money. They just wanted to be put back on as long as they were eligible. And thankfully, due to Michelle and others' good work, they succeeded. So if we're not medical people or legal people, how do we love our neighbors? How do we advocate for these issues? First off, it's important to be aware, to have knowledge about them. So we've put together a little sheet for you that's in the back, some things you can read and also some listening resources. Education is key, and then after knowing comes acting. What are things you can do? And again, we have just 2 or 3 or 4 suggestions that may be things you could do in the healthcare arena. Places where you might volunteer or give your time or service. And I emphasize again, write your lawmakers, call your lawmakers, be a part, let them know where you stand on these decisions they're making. Let your voice be heard, because enough squeaky wheels maybe will make an impact. Next week, we're going to have Councilwoman Berkeley Allen coming, and also Matt Wilshire, who's the Pathway to Affordable Housing nonprofit. They're coming to talk to us about the housing inequity in the city. So again, thank you. Thank you all for coming, for your interest. Have a good week, and I hope to see you back next week. And also, I'm also asked to remind you that outside Room in the Inn has sign-ups, so go ahead and get your name on there. Thanks again.